Good evening, everybody. Hello. I'm actually with you from Memphis, Tennessee, where I happen to be one of the hosts of Adam Arthur, who's one of the panelists today, sitting in my hotel room here. And welcome to the monthly University of Miami CV and Skull Base Symposium. This is session number 51 in a series, today on January 26, 2023. I will introduce the speakers shortly, but again, I'd like to always thank our co-directors of this marvelous series, Carolina Benjamin, Mike Ivan, Bobby Stark, and I think Carolina and Bobby are with us today as well, and our two current fellows, our external Cerebrovascular Skull-Base Fellow, Matthew Sun, and our infolded PGY4 Cerebrovascular Skull-Base Fellow, Eva Wu, and both of them will each show one case for our panelists to discuss. So here is Matt, who, by the way, has a wonderful job waiting for him and in Dallas at UT Southwestern when he's done with us. So congrats. And Eva, of course, has to pay her dues and finish her residency, unfortunately. Next month, save the date for February 23rd for a marvelous session on orbital lesions. As you know, we neurosurgeons really need to understand the orbit very well. It's actually quite a bit simpler than the brain. So fantastic panelists you can see there. Join us for that. And of course, you can review all the sessions we've recorded to date since the pandemic on our YouTube channel, and you can see those links there. As always, during the lectures today, at any time, go ahead and put in your questions in the Q&A box, and I promise you we will answer all of them by the end of the session. Now, my great pleasure to introduce in the order in which they are going to speak, about 20 minutes each, Chris Ogilvie, professor of neurosurgery at Harvard and at Beth Israel Deaconess Medical Center, of course, an extremely accomplished both open and endovascular neurosurgeon. And Chris is going to talk to us about small aneurysms to treat or not to treat, extremely timely and relevant topic in this area of era of what I think can be an era of abuse sometimes of treating tiny aneurysms. Second, Carlos. Carlos has moved after many years of being at Leahy Clinic. He's now professor of neurosurgery and vice chair of education and the skills lab and division chief of CV at University of North Carolina in Chapel Hill, where he joined Nelson Oyeshiku, just started this year. Carlos is going to talk to us about the optimal approach to a tough problem, the blister aneurysms, and that's always controversial, and that's going to be fun to talk about. And last but not least, Adam Arthur last year became became chair, professor and chair of the University of Tennessee Semmes Murphy Clinic here in Memphis, Tennessee, and of course, superbly accomplished open and endovascular as well. And he's going to talk about the role of stage treatment and retreatment of aneurysms. So there we go, enough of my monologue. So I'll invite now Chris to share his screen, unmute your microphone, and start your presentation.
Thanks very much, Jacques. Listen, thanks very much for the invitation. I really enjoy these sessions. And as you know, I jump on a number of them when I'm not speaking, but also love it when we speak because it really generates great discussion in our group prior to the meeting about the meeting coming up and the topic. So I'm going to talk about small intracranial aneurysms, big things happening with tiny lesions. And as Jacques says, there's a lot going on in practice that we're going to talk about, and I'd really like to get the discussant's perspective on some of this. I'd really like to acknowledge my partner Phil Towski, who's co-director here at the Beth Israel Deaconess Medical Center, and our clinical fellows Max Shutran and Michael Young, who've contributed to the discussions I'm going to talk about as well as some of the slides I'm going to show you. I have a few disclosures, none relevant to this presentation. And I thought for fun, I would just start off with this little, just show you a couple of really quick cases. This is a woman we saw about 2.5 hours ago in clinic for the first time. She's 58, nurse, has this left ophthalmic region aneurysm, 3 millimeters, red as an aneurysm. And it's detected after she thinks she's getting some word finding problems. No spells, but just sort of worse over time. She was a former heavy smoker, and her mother died from a ruptured aneurysm. So in Boston, this is a 1-hour discussion. And for Carlos's benefit, I put up the fact that occasionally these paraclinoid lesions come through unruptured, 2 millimeters, and they're read by radiologists as a blister aneurysm. And of course, as we're going to learn from Carlos, that is a completely different entity. But on the internet, it says blister. They got the diagnosis blister, and they come running to your office thinking they're going to die. And when really you're trying to reassure them how they need not only no more treatment, but barely any follow-up. This is another patient we saw this week, 43-year-old data scientist, has this tiny little bump on the ACOM. No family history, no smoking, and we're just going to keep an eye on this, and we can talk about what keeping an eye on it means in terms of how frequent. We've done a lot of work with how frequent scans should be obtained, what's cost effective, what's health effective, but he gets coital headaches, and that's why he got this scan. And this is a 60-year-old female, 2 millimeter ACOM, non-smoker, no family history. She has this tiny aneurysm, which we're watching and plan for follow-up imaging. So in decision making, obviously, we all just balance the natural history risks. That is, what happens if the lesion is left untreated against the treatment-related risks. And size of the lesion is only one of the factors in this whole process. So I'm just going to review a little bit, some things that are published, some things that aren't. Natural history data that's, and the data is evolving to try to stratify the risks of individual lesions based on several overall factors. And then treatment-related risks. And this is where the pendulum is swinging very quickly, because these involve lesion and patient-specific factors in terms of the risks of treatment, but also our tools of treatment, I think, is what Jacques was alluding to. As they get safer, we have to be careful where these are offered and whether this justified. So for the natural history, there are both patient and lesion specific factors: size, location, age of patient, because that dictates life horizon. And then risk factors that are modifiable: smoking, ethnicity, which is not, and female, but these can influence the natural history of an aneurysm. And then the risk of treatment, which are also patient and lesion specific factors: age, size, comorbidities. There is decreasing risk with improved technology, as we'll look at. And we, as I think all the speakers, use both open and endovascular techniques to select the lowest risk, highest efficacy type of treatment. In terms of the natural history, I'm not going to drag you through all these studies, but this is what we talk about and use when we couch our discussions often with patients: the International Study of Unruptured Aneurysms, the UCAS, the Japanese study of unruptured aneurysms, which is basically a rehash of the ISSUA trial, but I'll show you some caveats about that. Some meta-analysis, and often the phases score comes into discussion. In terms of the international study, this is a diagram or a table that sometimes patients bring in their pocket to the office visit. And as you'll all remember, this is the second publication of the ISSUA trial. The first was in 1998. This was in 2003. And there's, of course, two groups: those that had no previous history of subarachnoid hemorrhage and those that did. The point I'm showing this is it's for the first time is when the ISSUA data was really broken down by location, what they called anterior and posterior circulation. And we all know there's many caveats to this data, many editorials written. But basically, patients will come with this and saying, gee, I am group 1 and I have a less than 7 millimeter aneurysm, so I have no chance of a hemorrhage. Well, nothing's zero, of course. And then it stratifies the risk not only by site, and here for posterior circulation lesions, I think everyone knows these were vertebrobasilar and posterior communicating artery lesions, which some argue should not be included in that. But then obviously size does influence potential risk of rupture. Well, following this study, small aneurysms were typically considered less than 7 millimeters. And interestingly, despite this study showing that little aneurysms had a really low incidence of hemorrhage in this study, it was in the New England Journal, so lots of general physicians got hold of this data. And interestingly, the number of unruptured aneurysms treated in the United States actually increased after this publication, despite the issue of data showing higher surgical complications when followed prospectively than previously reported, and that the rupture rates were lower than previously reported. This is a paper from 2021 looking at a national database, looking at the national database data, and I think we all pretty much know this well. But now you can see 2003 on this study, on this graph, for treated aneurysms, which is when the ISSUA trial was published for the second time, there was a big jump in the number of aneurysms being treated. And this shows those unruptured versus ruptured, but the number of unruptured lesions went up significantly. And as we all know, I think the aneurysms diagnosed for unruptured aneurysms has ascended and crossed those with subarachnoid hemorrhage. And then there's the other graphs here to show that endovascular treatment is used more frequently than clipping for unruptured lesions. And this really harkens to the fact that the paper was published and more lesions were being treated. And part of that's related to this glaring fact, that is, when patients present with aneurysmal subarachnoid hemorrhage, 75% have lesions less than 10 millimeters. So when unruptured lesions are small, they're less likely to bleed, yet when aneurysms bleed, they're likely to be small. And we've all clipped a 5 millimeter ruptured MCA aneurysm, come up to the clinic and see a patient, and they have the exact same lesion on their scan, and we're left with this discussion. This is a paper from Cornell from 2017, and they looked at epochs of subarachnoid hemorrhage versus size. And you can see that they looked at lesions smaller than 5 millimeters. And basically, over time, what we're seeing, and these are the different epochs shown here by time interval, but over time, the number of lesions or percentage of lesions 0 to 5 millimeters has been increasing, as you can see here. Enter the Japanese study, which now is 11 years old, but it's still data that's talked about quite a bit. And this study was important because it did stratify patients' risk of hemorrhage by not only site, really more detailed and more granular than ever before, but also by size. And really the interesting thing are these 3 and 4 and 5 and 6 millimeter groups. And then these curves on the side show the stratification of these based on probability of rupture, based on these various factors. This is a graph from their publication, but what it shows is there was a fairly high number of 3 to 6 millimeter lesions. So this drove a lot of the data in this study. And as we all know, really, the conclusions of this study, some in keeping with what had previously been shown, some which wasn't, but greater than 7 millimeters increased risk of rupture, ACOM and PCOM, but not posterior circulations, where it significantly increased the risk of rupture. And women and patients with hypertension had increased risk. But interestingly, prior subarachnoid hemorrhage, smoking history, and family history, and the presence of multiple aneurysms were not associated with increased risk of rupture. But then here, and it shows those relative risk factors and hazard ratios. But we're starting to see data of ruptured and unruptured aneurysms stratified by size, sate, and the other thing the Japanese study showed first time really statistically was that irregular shape, that is irregular shape of the aneurysm, carried with it a higher risk of rupture. This is a follow-up paper from Journal of Neurosurgery in 2020 by the same authors, and it's a bit of a difficult read, at least for me, but they looked at the risk of small and ruptured aneurysms bleeding, and this is from that paper. And you can see these were the number of patients entered into the UCAS study in the blue bars, and you see a very large number of small aneurysms that were in this study. And then they went ahead and looked at the rupture rate, which you can barely see the line on the bottom of the graph because it's a dashed line down here. And then the treated aneurysms, many aneurysms treated in the small size range. So the conclusion from this paper was that most of the UCAS aneurysms were small, 25% 3 millimeters, 22% 4 millimeters, but most common ruptures were in the 7 millimeter range, and that there was an annual risk of rupture for 3 and 4 millimeter aneurysms, as you can see here, although it was very low. And that the risk for small aneurysm rupture were the significant factors were prior subarachnoid hemorrhage, uncontrolled hypertension, ACOM, and discovery on what they called screening brain checkup. Well, this is a graph I made using binomial theorem to predict risk of rupture based on some of the UCAS data. And you can see that for the 7 to 9 millimeter lesion, this is number of years of follow-up and risk of hemorrhage over time, that the number becomes pretty significant by 2 years, you're above 3%, and by 5 years, you're up around 8% risk of hemorrhage. However, there is a number for the 3 and 4 millimeter lesions. By 5 years, you're running about a 1.8% risk of hemorrhage. And this kind of thinking and data, I think, is partially driving what we're seeing, which is more smaller lesions being treated in the unruptured state over time. Well, how about multiple aneurysms? Here's a patient who's 50, and you can see she has 4 small aneurysms. Does she have? She does not have, as we all know, 4 times the risk of rupture of one aneurysm. I think it is higher. I don't think it's known statistically how much higher that is. So I posit the question, does a patient with 3 unruptured aneurysms have triple the risk of hemorrhage? And we say no. It's probably increased, but by how much, it's not known. But if one is bled, as all of you know, the patient is often extremely motivated to treat the other lesions, regardless of size. And that enters into the psychology of the aneurysms. And then there's autosomal dominant polycystic kidney disease. Here's a 61-year-old who had polycystic kidney disease. She had a successful renal transplant, strong family of aneurysmal subarachnoid hemorrhage, and she has this A1 lesion, which is irregular in shape. She has no M1. It was occluded asymptomatically. But after lots of discussion with this woman, here's her 3D. You can see it's an irregular shape, little 3 millimeter thing. We went ahead with surgery. And of course, at surgery, as all of you know, especially in the polycystics, these are red, very angry looking lesions. Here's a perforator next to it. The M1 was occluded. And this is actually the M1, this white thing here and down here. But we went ahead and clipped this, and she did well. Should we have done that? We can discuss that. And the phases score is many people use to help guide decision making, but in terms of size, really you only start to get points on the phases score for size above 7 millimeters on up, and then that adds to the risk of rupture. And then, of course, as I mentioned earlier, there's the anxiety over an unruptured aneurysm. And at least in Boston, we spend a lot of time in clinic reducing anxiety and telling people why they don't need treatment as opposed to why they do. Family history enters into this. If they've seen a loved one die of an aneurysm, I've had patients tell me, I don't care what size it is, I want it fixed. And then there's the physician anxiety, that is primary care physicians who learned in med school that aneurysms were dangerous, so they should get treatment, which actually, as long as they end up in your hand as the expert, probably isn't such a bad thing. So natural history modifiers, size, location, lobularity, and multiplicity of lesions, possibly. Patient-specific factors, younger patients, because they have a longer life horizon. So the 30-year-old with a 4 millimeter aneurysm may have a very different consideration and discussion than the 78-year-old with a 4 millimeter aneurysm. And then there's the family history, ethnicity, their anxiety, and smoking, which I think plays a huge role in growth and rupture of these lesions. Now, let me just flip the coin and look at the treatment-related risks, and then I'll finish up. And just like with natural history, there are patient-specific factors and lesion-specific factors for treatment. As we all know, size, increased risk with increased size, location, calcification, and local anatomic details. And this is true for both endovascular and surgical strategies. So there's stratification of treatment-related risks. And I think we can all, and we all do this in our practice, basically highly select treatment, which is appropriate for each patient. But the treatment risk is not static. And as the surgical specialty progresses, we see a change in this. This is a paper we published a couple of years ago, and it's using endovascular and surgical management to look at outcomes from unruptured aneurysms. And we had 658 aneurysms in a little over 550 patients. And the other point to be made for this paper was during the same interval, we evaluated 950 patients, which merited no treatment whatsoever, and were followed or told they don't need any follow-up during the same interval. But basically with this, we were able to get risks of treatment versus size and location of aneurysm. And we compared this to an earlier series that Bob Carter and I had published in 2003 with about the same number of patients, very similar distribution of age and sizes. I can't lay the graphs on top of each other because our previous study was Glasgow outcome score and the current study was modified Rankin score. But when using both endovascular and surgical results, these lines show various sizes in the anterior and posterior location. And that's what these bars show. And for our surgical series, it's the same thing. I won't drag you through the statistics we use to generate these curves, but basically for the posterior circulation large lesions, you can see the distribution of outcome in terms of poor outcome based on patient age and size of aneurysm. This is a 15 millimeter posterior circulation lesion as age increases, whereas a small aneurysm in the anterior circulation, 5 millimeters, has a risk profile much lower, but still only surgery has a higher risk than combined modality management. So overall treatment risks of unruptured aneurysms are decreasing over time, and that's because of increased use of endovascular techniques, better surgical results. So the question is there changing for the criteria? Flow diversion has certainly driven some of this. Are more lesions being treated, smaller lesions, more paraclinoid lesions, and are older patients being treated? I'll show you a few more slides and stop. This is what neurovascular specialists say they do, and this was a survey we did published last year, where we asked interventional specialists, neurologists, neurosurgeons, and radiologists management of certain aneurysms. And for 2 to 4 millimeter aneurysms, you can see here that most favored surveillance, only a little under 4% favored routine treatment, and a little under 9% favored treatment if there was some high risk feature. And then we looked at intervals of treatment, which is a different part of this paper I won't get into. When we looked at 5 to 7 millimeter aneurysms, look what happens to the decision making. Routine treatment should be considered, 73.5%. And when you combine that with the high risk patients, it's almost 80% of lesions which are recommended for treatment. And this is still up to 7 millimeters, not over. So is there a change of unruptured aneurysm being treated? The lower overall risks of treatment using endovascular and surgical techniques. Is this affecting the size of aneurysm that's being treated? And will artificial intelligence influence the monitoring of growth and decision-making for intracranial aneurysms? You've seen some of the papers that are being published on artificial intelligence following aneurysms. We all know now there are artificial intelligence programs that when a scan is done within your hospital system, an aneurysm pops up. It doesn't matter if it's 1 millimeter or 10 millimeters, it goes right to your cell phone. No neurologist, no interventionalist, no radiologist, right to your cell phone, and you're left figuring out what to do with it. But some of the recent papers are suggesting that the linear maximal measurements that we have made with cursors may be inaccurate, and that actually a volumetric type analysis may be a better analysis for these lesions. So it'll be interesting to see as these small lesions, if AI picks up small changes in growth, would that be utilized for a criteria for treatment? Now, I said to you what neurovascular specialists said they were doing. Here's what they're actually doing. And this is data that's not published. We're working it up for publication, but we reviewed the world literature. And you can see here, this represents over 35,000 patients in 240 studies. And this looks at aneurysm size treatment over time. And the various dots represent each study, and the sample size of each study is commensurate with the size of the dot. And then here's a bar graph showing the same thing. But for all aneurysms that we could find, and there was search criteria, I won't get into at this moment, but you can see between 1990 and 2020, the average size of aneurysm being treated is coming down pretty dramatically. And this is true for both endovascular reports and for open surgical reports. In addition, we looked at developed and underdeveloped countries, and many fewer patients to evaluate that are published from underdeveloped countries, a little over 5,000, whereas there's almost 30,000 for developed countries, but the same type of trend is going on. And then we looked at different parts of the world. You can see here, East Asia, pretty stable, Europe, with a decrease in treatment size over time, and the United States with the largest change over time. And then we also looked at who was treating the lesion. And when you looked at neurosurgical specialists, and this is both endovascular and surgical management, you can see the graph here versus other. This would be neurointerventional neurologists and radiologists, and you can see what's happening with size of treatment over time. So I will finish there. I hope I didn't run too much over. Unruptured aneurysms warrant careful consideration with multiple aneurysm-specific and patient-specific factors weighed for natural history and treatment-related risks. And as our imaging tools improve, a lot of us are using wall enhancement. We don't know exactly what to do with that yet. Shape and flow analysis and artificial intelligence, we may better develop indications of small aneurysms at higher risk of rupture. So I'll finish there, and thank you for your attention. Appreciate the opportunity to present this.
Thanks, Chris. Thank you very much. I usually will keep the discussion till after all three of you have spoken, but I'd like you to come back in the discussion time and talk about aneurysms that are documented to have grown on follow-up from 2 to 3 to 4, what evidence we have that they should be treated and so forth. But anyway, you don't have to answer me now, but something we could all discuss later. If you can stop sharing your slides, and I invite Carlos to talk about the complex topic of blister aneurysms. Great review, by the way, Chris. Thank you. Great work.
Okay, you guys seeing it?
Yes, but go to presentation mode. There you go.
Good. Good.
Perfect.
Okay. Thank you, Jacques, for the invitation. I think, if I remember correctly, I was present for the first one that you did, and we were presenting cases, I think, to Dr. Spetzler. So it's nice to be coming around the circle 50 times later. And yes, Chris, you're right. The Boston patient is very different. I'm getting used to the patient here that doesn't do that, but just as an anecdote, I had a Boston patient recently, and I saw her in post-op a couple of days ago in clinic, and she was all happy with everything. And then she said, but I have a few comments, and she pulls out her little notebook, and I felt like I was right back in Boston, and it was complaints about the food and the nurses and everything else. All right, blister aneurysm. So I was charged with, is there an optimal management approach? And I'm going to try to do this. And I need to acknowledge my two PGY6 superstars, Nathan Quigg and Darshan Shastri, two phenomenal residents who are looking to become vascular surgeons, endovascular surgeons, and skull base surgeons. So keep an eye out for them. All right, my disclosure has nothing to do with anything here tonight. So what is the problem? So, these are, like Chris said, the radiologist might call something a blister, but it really is a completely different disease. These are rare, extremely thin, fragile walled blisters, technically, on the blood vessel. They tend to occur on that supraclinoid portion of the carotid artery, but we've come to identify them in vessels basically anywhere. And it's interesting, if you go back through the history, O'Hara was the first to kind of remark in 1979 that these needed a completely different management than the standard clipping. And it was Takahashi who came up with the term kimami in Japanese, or blood blister aneurysm. And again, we're seeing them in other vessels as well. So they're supposedly due to subadventitial dissections that lead to a defect in the wall, and then basically the rupture and the subarachnoid hemorrhage. Luckily, they are pretty rare. They're about 1% of all aneurysms, and about 0.5% to 2% of all ruptured aneurysms. The issue is they have an extremely high rate of re-rupture in a very short period of time, and a lot of times unless you're very suspicious or looking or thinking about them, and I'm going to show a couple examples, you may not see it, or they may not show up at all in the angiogram. And the reality is there an optimal management? Well, they've posed a challenge from both the surgical and the endovascular route, and they generally tend to have high-grade hemorrhages and poor prognosis. And here's a picture of one basically that you see here, the red kind of blistery look to the vessel. So why do these occur? There really is no conclusive pathogenesis. They feel that based on the studies, there's arteriosclerotic factors, hypertension, dissections potentially. What's interesting is that they do not have an intimal or medial layer. They're really covered by just a fragile fibrous layer, and sometimes they're true false aneurysms being held together by a clot. And that's in contradistinction to a standard saccular berry aneurysm that we all deal with, that have the multiple layers that are broken down with inflammation and smooth muscle proliferation and apoptosis. The current feeling, though, is that atherosclerotic remodeling may be the main cause here, that you get ulceration, destruction of the intima with a hematoma that eventually leads to breakdown. Interestingly, Bojanowski tried to create a classification scheme. I'm not sure exactly how useful it really is, but basically he described the what he calls a type 1 as classic, being a part of the wall, like a blister on the wall without really a sac. A type 2, which is more berry-like, but the neck is not longer than the diameter of the vessel. And then in type 3, the neck is longer than the diameter of the vessel. And then type 4, basically it's a whole circumferential blowout. So what are the treatment considerations? They're challenging, they're difficult for both surgical reconstruction and for endovascular treatment. You know, this high rate of re-rupture, and they have a very high rate of intraoperative rupture, and I'll share that with you with my own videos. And so there have been the direct clipping, the wrapping and trapping, bypass with trapping, occluding the artery. These are all options that have kind of been used for these. The endovascular route, they started with coiling, then a stent-assisted coiling, then multiple overlapping stents, and more recently, it seems like flow diversion is becoming kind of the mainstay and the treatment that everyone's falling on. The point is that there's not been one treatment modality that's proven distinctly superior so far in the literature. So talking about surgical options, there's, you know, standard clipping, but frequently there's just too much diseased wall that it has no integrity to pull it together. So you can fall back on the sunk clip, which is not made anymore, or we can do what we call the wrap clip. And give Chris a chuckle here. I remember being a fellow for Dr. Spetzler back in '97, and every day we got a few articles to review for him for his editorial duties for the CNS Journal, the Red Journal. And I remember reviewing a technical paper by Chris on using HemoShield to wrap and use a clip to kind of the poor man's, or I guess the rich man's, stunt clip. And so basically it is a technique that's been used, and there's several Japanese papers that really argued in favor of that technique. Using plain old cotton, you know, the Dr. Spetzler and Dr. Barrow as to who came up with it, but using cotton and a clip to kind of pull things together. And then, of course, vessel occlusion with or without a bypass, or trapping with or without a bypass. The endovascular route, again, coiling, stent coil, vessel occlusion, flow diversion with coils, without coils, overlapping stents or flow diversion, all of these have been tried. It seems like the flow diverting method is optimal so far amongst the endovascular routes. The issues are vasospasm, and then again, dual antiplatelets in someone with a really bad subarachnoid hemorrhage who needs the EVD, may need a shunt. So these are the issues that kind of affect this treatment. Whereas for the surgical treatment, I failed to mention, the main issue is intraoperative rupture and stroke, which tends to be higher. So here's an example of a case I dealt with a few years ago. I want to say like back in 2011 or 12. And this was a 46-year-old hospital CFO who was found unconscious next to his desk. He was a GCSS7 and hemiparetic on arrival. And his CT showed really extensive subarachnoid hemorrhage, as you can see here. And interestingly, he had been down for several hours, and I don't know if he embolized or what, but he started showing signs of ischemia. And this is his pre-op scans in his internal capsule and so forth. And, you know, we did the CTA, which, you know, back then, my suspicion was not as high for these as it is nowadays. And I almost overlooked this completely. And then we did the full 3D angio, and INSUP shows me this little bump, and I was like, okay, I guess that's it. So we took him to surgery, and you know, this is what we found. Let me just move the video where it gets a little better. Here I'm basically putting temporaries above and below it, and you see this almost blowout of the whole wall, and a lot of it was actually ventral. And as soon as I start playing with it, of course, it starts to bleed, and you'll see that here in a second. You'll see the blister on it right there. And, you know, this guy was poor grade. I was not ready to do a bypass in the situation. Brain was very, very swollen. And as soon as I touch it, watch, it starts to go. Again, just argues about how fragile these things are. And still, you know, pretty brisk bleeding considering. And again, most of this was ventral. So it was one of these where I ended up having to pull out a fenestrated clip and reconstruct the vessel as best I could without narrowing it too much. And I achieved that, but I was worried about this, dorsum, which was also very, very blister-like. So in that situation, basically I put some cotton on it and then used another clip to kind of pinch that cotton onto that area. And surprisingly, there was the ICG angiogram. Surprisingly, this guy did extremely well. He recovered. He ended up needing a VP shunt for hydrocephalus. And, here's a CTA, which is, I think, like a 7 or 8 year follow-up, which is the last time I saw him. And, he actually got back to work. And it was a miraculous save, given how bad he was coming in. Here's a second case, and I may want to stop this one and just ask Adam and Chris what they think. So here's a 51-year-old who comes in with the explosive headache and the subarachnoid hemorrhage, and he's got this. And you see this kind of weird widening here. And now you see this. And so basically that whole A1 transitioning into the A2 segment is diseased. And, I think my talk's gonna be a little shorter than the 20 minutes. So I'll go ahead and maybe get you two to just give me a comment. What would you guys do with this thing?
Probably flow divert. I guess I'd like to see better pictures. The other thing is almost none of my rupture blister aneurysms are men. You showed 2 men in a row. I don't know if that's just a weird sampling error, but for years and years, it always seems to be relatively young women.
No, for me, it's been men, honestly. So this was a Sunday afternoon, Insup's out of town, and I don't think back then we would have flow diverted this. This was quite a while ago. So, I took him to surgery just to see what I was dealing with, and I'll speed this up. Here's a better view of it. You can see the backside there. It had like almost a different sac coming out of it. But my concern was, I'm getting temporary control here, just preparing the A1. And then moving along the chiasm, let me just move this forward a little bit. And you'll see again, it's one of these where as soon as I touch it, so now we're starting to come up on it, you're starting to see the diseased vessel there. And as soon as I touch it, there it goes. And of course, to get it under control, bring in a patty and the cotton ball and so forth, get the temporary clip on. And what I end up finding, and okay, here it is now controlled. I've got a temporary clip on the opposite A1. Here it is involving the communicating segment, and this is all diseased. And I'm looking at this going, I'm not sure how I'm going to handle this. The bleeding point was here. And lucky for me, that bleeding point had a perforator free. There was no striates coming off in that area. So I was able to trap the bleeding point. I had good enough backflow from the other side. And essentially I trapped that segment, and then the part that was distal, that was involving that communicator with the branches coming off, I end up coagulating. Let me just get to that part there. This part I end up just coagulating and covering with cotton and called it a day. And that's why I was curious. I think today we probably would have flow diverted this, but again, these limited options to deal with this. So what about this? So here's one where, again, as Henri Bergson said, your eyes see what your mind's ready to see. So this person comes in with a Hunt, has 4, subarachnoid, gets better after an EBD, and he's got this large ACOM. And so I see the little bump on the carotid, but I don't really think anything about it. And I'm going in to clip an ACOM. And as soon as
I got that classic, almost volcano-like appearance, right? And it's right in the wrong place.
Yep. So I can't remember if it was Max Schutron, who was actually the resident with me for this one. But and it's one of these, I wish I had video, but it was as soon as we opened the dura, this is what I dealt with. It just was a bloodbath. And I remember thinking to myself, the blood's shooting from the wrong direction. It was like a sprinkler coming from the carotid side versus the ACOM side. And it suddenly hit me, oh man, this is a blister that blew. The ACOM's intact. We got it under control. Everything went fine, but it was just, you weren't prepared mentally. I was looking at that ACOM and I was totally fooled by this thing. So here's one I guess it can happen to my endovascular colleagues as well. This person comes in with a subarachnoid hemorrhage, and they have this superior hypophyseal on the left side. They had this little anterior temporal aneurysm on the right side. And there's this, which was kind of overlooked. And they went ahead and treated the supraepiphyseal and the MCA anterior temporal branch. And a few days later, the patient has a rebleed and they take her back. And now we've got this situation where you see the whole Wall's disease. There's the aneurysm. They put a few coils in it. Would have loved to pipeline this, but look at the spasm. And I'm just wondering if you guys, what other option would there be here? You know, I don't think there's a surgical option for this at the situation with that much spasm. And so, you know, this is how it was treated. And unfortunately, the patient ended up succumbing and did not do well from all the rebleeds. I don't know.
Did it rebleed from that construct though, or was that okay?
So no, they did this and then it rebled again, and that was it.
It's a shame because we did have a woman with a gunshot wound and a pseudoaneurysm that we just waited out the spasm day by day. When it got just big enough, we put a flow diverter in, but it was literally just waiting for that spasm to resolve. So that's a shame.
Yeah, no, it was disappointing. Yeah, and again,
hindsight's 2020, but you know that last picture almost makes you think about a bypass, right? Bypass and occlusion of the carotid. I mean, the patient probably would have done terrible no matter what. That's another thing in my population. Not only are the blisters all women, but they have an incredibly high severe spasm rate. Is that something you've seen, Carlos?
Yeah, me too. And you know, I bypass. I'll be honest with you. I'm afraid to do a bypass in the setting of that much spasm. And so
they don't do well in the setting of a spasm. It's a terrible time to do it. You make it.
I think these examples are kind of showing you what we're talking about. You know, they're just bad cases. This is a bad disease. Here's another one where, you know, this angio was read as negative initially, and then they repeated it 7 days later, and now look what you have. So they coiled it, and then it grew back, and then eventually they did treat it with a flow diverter, and it did phenomenal after that. But it just, you know, it shows you we have options, but really, what is our decision making when there's no perfect answer? And so I'm just going to go through the literature real quick. You know, and we have a smattering of small case series. There's definitely a few meta-analysis and some comparing the various different modalities. I don't think we can draw conclusions concretely from any of them, but you know, I'll give you my thoughts at the end. So here's a study from Linfante's group, and basically it's small numbers, but retrospective, but they achieved 87.5% complete occlusion with endovascular treatment, and they had 3% persistent filling. And that seems to be the issue with the endovascular treatment is, you know, the persistent filling and the vasospasm and dual antiplatelets. Those are the main issues. Here's another very small series using pipeline, and, you know, they found 100% occlusion, but they had a 25% complication rate. And again, granted, small series. This one is interesting because they were trying to use just a single antiplatelet versus dual antiplatelet. Again, generally small numbers, but the results were pretty good. And so it brings up the question, do we really need dual antiplatelets in this situation? This paper by Sclerati and so forth was the first big meta-analysis. They looked at 32 studies, 684 patients. Endovascular methods were really the focus of this paper. And they had a 77% occlusion rate, about a 9% complication rate, you know, and good outcome defined MRS less than 2, about 77% almost, and a 4.7% mortality. I'd say those numbers are pretty good considering what this disease is, really. Then we had this one, and, you know, this is a pretty good paper from Jeremiah Johnson's group, where they looked at 102 studies. They had 687 surgical patients, 125 flow diverter patients, and then 700 or so other treatments. And what they found was that what we know, surgical treatment was most associated with intraop rupture, stroke, vasospasm, but it had the highest occlusion rate. And flow diverters seemed to have the lowest complication rate. The highest retreatment and incomplete occlusion rate was stent coil and all of those variations. And interestingly, there was no difference in functional outcome in the long term. So again, what do we do with this data? Here's another paper by the Smudas. They looked at optimal treatment, mortality, outcome, rebleeding, recurrence. They had 117 in the surgical group, 173 in endovascular. And again, they found no treatment was superior, but stent coiling and those type of endovascular therapies seem to be the ones associated with the highest need for retreatment. And then finally, this compilation of all the meta studies, basically comparing all of them. Again, mixed results, no consensus. There's superiority of microsurgery in terms of the definitiveness of the treatment, but there's less complications and less peri-procedural morbidity with endovascular therapies. Really, flow diversion is what they're talking about here. Surgical option provided 90% occlusion rates. Trapping with bypass showed the best outcomes in the surgery groups. And then the endovascular therapy, like we know, significant number of incomplete occlusions and need for retreatment. So, it's a trade-off one way or the other. So is there a best option? I think this cartoon really sums it up best. Old Faithful, boom, versus young and unreliable and less chance of an intraprocedural rupture. So, to kind of sum it up and give you my thoughts, I don't think we have an optimal answer. I don't think there is an optimal treatment, and it's really going to boil down to the expertise of the center and their experience. For me, at our institution, it's really age of the patient, grade, the hydrocephalus, need for an EVD, risk of vasospasm, summing all that up and deciding. And I tend to lean towards endovascular. I'd rather have them deal with it and put a flow diverter in if that's the best treatment for that specific scenario. Otherwise, my experience, I've surgically clipped with the cotton and the wrapping and the HemoShield. I like that method. I will rely on bypass and trap when needed. I may shift now based on what I'm reading in the meta-analysis. But I've found that I've not needed to do bypass in that setting with the hemorrhage and so forth. And I've relied mostly on surgical clipping. But again, for me, I think flow diversion seems to be winning out as the primary treatment. And I'll go ahead and stop here.
Thanks, Carlos. Excellent review. By the way, again, I remind the audience, don't be shy about writing your questions in the Q&A box, and we will address that at the end. Okay, without further discussion for now, Adam, take us home with your presentation on retreatments.
Okay. Well, those were two pretty tough acts to follow. Are my slides showing up okay?
Yes, very good.
Okay. Of note, I am the PI of WebIt, and I'm going to talk about Web. I'm also, and my employer's paid for that. I'm also PI of a study sponsored by Medtronic on treating ruptured blistered aneurysms with pipeline shield. So that's something we can talk about later. But I'm going to give a little brief background because I think to some extent there's some overlap with what Chris talked about and what I talked about, because we're really talking about who we should treat and who we shouldn't. And whatever your treatment in whatever situation, we've got to worry about beating the natural history. And I thought Chris's talk was great, looking at natural history and his decision analysis. He reviewed some of the literature on unruptured aneurysms. And so I don't have to, which is great. I'm a lazy man and I prefer to let Chris do the hard work. But here's a patient with an unruptured aneurysm. It's a little bit pedunculated. And this is a case that we treated with straightforward coiling. So there's the aneurysm. Here's the initial coil, and here's the final result. So this is not a complete treatment. There's clearly a neck. But at least in my practice, this is an example of somebody that I'm not going to bring back and retreat or flow divert over that neck as long as that maintains a stable position. I think this is the kind of patient that more and more in this day and age is undergoing multiple treatments to get a perfect angiographic result. And I think that's a little problematic looking at the literature. We know that most incidental aneurysms are not going to rupture, but we're seeing them more and more and more. I had a colleague who calls patients who are referred for an incidentally described aneurysm victims of medical imaging technology, or VOMIT for short. They come into clinic, they're terrified. As Chris mentioned, you really want to counsel these patients. They think they've got a ticking time bomb in their head. And you don't want to be this guy. Fear or anxiety is never a good reason for a craniotomy to clip an aneurysm, in my opinion. And I think in this day and age, we really have to be aware that if you're a cerebrovascular practitioner, either open or endovascular, your aneurysm patients come in two flavors. It's a bimodal peak. There are patients who come in with a ruptured aneurysm, and whether it's a bad rupture or it's a little rupture, those are patients who are in the ICU and they have real risks. They have risks of vasospasm, re-rupture, treatment-related risks. You talk to them and their patients differently. You view those risks differently. And then there are the patients who come into your clinic terrified. That their primary care doctor, their neighbor, somebody's terrified them. You cannot conflate these two populations of patients. And I sometimes hear people conflate these two populations of patients. They have to be treated differently. They have to be thought of very differently. In terms of staged treatment, I think that is a treatment which, with flow diversion, has become very feasible. So for a patient who has an aneurysm that you really think you want to dome protect with coil or web, and then come back later and flow divert a sidewall aneurysm, there's literature, and this out of Mayo is one of the best papers that indicates this is a very reasonable treatment. Now, I feel very different about terminus aneurysms. There's more and more off-label use of flow diverters to retreat terminus aneurysms, and although single center or multi-center case series show that they can do that, or you can do that in some cases, it's not a really well-studied strategy, and I certainly have seen complications related to it. But here's an example from a case report in the literature of the kind of strategy I'm talking about. This is a ruptured PCOM aneurysm. It's fairly wide-necked, and after work, they were able to get it coiled to the point where it's probably not going to re-rupture in the immediate short term. I think the off-label use of an intrasaccular flow disruptor is also possible in this case. Then they go back, in this case, in 2 weeks, and they perfect that angiographic appearance of the flow diverter after the patient's out of the vasospasm window, out of the hydrocephalus window. This is increasingly a strategy that's pursued in many centers, and I think it's reasonable. I think you always should consider a single treatment. Could this patient have just been clipped? Certainly. But in cases where the anatomy is complex or the patient's frail or very ill, I think this is a very reasonable stage treatment. What about the web? Well, the web could be used off-label in that case, but the web results do indicate that this is a device that can be used very quickly and efficiently without using any platelet agents, but there's a lot of recurrences. The question becomes, when should you treat a recurrence? So these data are not yet published, but we're working on them, and I presented them before. These are the 5-year results of the WEBIT study. And what you'll see right away is that there were retreatments in all 5 years, right? So there was a fairly significant retreatment rate in these 150 patients treated in a good clinical practices study with adjudicated data. The overall retreatment rate was about 15.5%. So we know that as aneurysms heal, the web gets distorted or modified, and this sometimes can result in a perfect looking angiographic result as the dome of the aneurysm shrinks toward the neck. But in other cases, the web kind of gets scarred up and you end up with a neck remnant. So I can show you some of the retreatments in WEBIT. I can show you that the retreatment rate seems to be, although it's not statistically significant, higher for MCA aneurysms, which is interesting. As we look at more data and combine this, maybe that indicates that this is something that we need to pay attention to. Here's a basilar aneurysm that was treated at my center within the WEBIT study. Not an easy aneurysm to clip, certainly would require stent assistance without the web. And here's the web in place. It seems to be placed very well, but I want to draw your attention to the right ventral portion of the aneurysm where there's clearly a chin or belly that is not being well covered by the web. What we see is that those cases are setups for a growing neck remnant. So is this patient protected from an acute rupture? Sure. The dome is protected, but here was a substantial recurrence that was treated with stent coiling. You could argue that maybe this didn't need to be retreated, but it was in this case. Here's a ruptured patient treated within the WEBIT study. She had an ACOM aneurysm. Here's the web placed into the ACOM. I want to draw your attention again to the daughter sac that is hanging down, that is clearly not protected by the web, probably not the source of rupture. So maybe it doesn't need to be treated right off the bat, but this is a setup for a recurrence. And here you see the recurrence. Now that recurrence can be treated in a staged fashion, so maybe this wasn't a terrible result, but I think these are reasonable retreatments. I want to point out that the two significant aneurysm-related morbidities or mortalities in the 5-year study are both, interestingly, patients who have very small, unruptured ACOM aneurysms that were treated, had small neck remnants that were retreated safely. But then in both cases, 2 different centers, the investigator embarked on a third treatment of a millimeter or 2 neck remnant of a 4 to 6 millimeter treated ACOM aneurysm. In one case, this resulted in a stent occlusion and eventually rupture of an A1 and death. In the other case, there was a distal wire penetration. So I'm showing you the results here. A reasonable web result, 6-month follow-up, and then 5-year follow-up showed no worsening of the recurrence. A flow diverter was used in an off-label fashion in the terminus aneurysm. And then even after the flow diverter, there was still some filling. And so they went to do, just like in the other case, a third case and got a distal wire penetration that was eventually treated with liquid embolic and resulted in a significant stroke. So when should we be retreating these? Well, I think the 2 big questions are, when you're treating an unruptured aneurysm, once you've told the patient, I'm going to treat your unruptured aneurysm, do you then have to continue to retreat and retreat and retreat until you get a perfect angiographic result? And then the second thing is, if you've treated a ruptured aneurysm and you end up with a small neck remnant, particularly after clipping, but even after coiling or web, are you committed to treating them again? And I think the literature tells you that the answer to both those questions is no. Here's a 55-year-old with a previously ruptured aneurysm. Here are the CARET data on the rates of delayed rebleeding from intracranial aneurysms. They're extremely low. Once an aneurysm has been reasonably well treated, they're back to being unruptured aneurysms. The predictors of hemorrhage are things like the person years and whether you're dealing with a true dome residual or a residual neck. And residual necks, no matter how the aneurysm was initially treated, are extraordinarily low risk of rupture. We see this in ISAT-2. ISAT patients treated endovascular were only coiled. There wasn't any advanced stuff going on in that era. And whether it was coiled or clipped, even when there were neck remnants, there were very low rebleeding rates. So the CARET data indicate that for this relatively young 55-year-old healthy woman who has a previously ruptured aneurysm, when there's a recurrent neck, the lifetime rupture risk for this patient is under 4%. And when you're dealing with a natural history risk that's under 4%, I would argue that probably in most centers that should not be retreated. What about growing aneurysms? Well, when aneurysms grow, there is evidence that they're higher risk. I like this paper in JAMA that is just in the last couple of years that looks at the various things that increase the risk. They look at the S's, so site and whether they're regular or irregular, and size. So one of my predecessors here at Sims Murphy was a phenomenal aneurysm surgeon named Morris Ray, and he once wrote a monograph called Thoughts While Shaving. And all of us who treat aneurysms have these moments, whether you're shaving or in the shower, when you think about these things. I don't see a lot of unruptured pica aneurysms, and UCAS gives us almost no data on pica aneurysms. The rupture rate for distal anterior cerebral artery aneurysms is much higher at a lower rate. I don't think a one-size-fits-all approach to when it's safe to take a staged or a retreatment approach is feasible. We have to deal with uncertainty and probability. But I can tell you that I really don't think that we should be embarking wholesale on retreatments of small neck remnants of previously treated aneurysms, whether they were originally ruptured or not. I think we probably are doing that far too much, particularly in the United States. The WEBIT data show this. The retreatment rate in the US for a webbed aneurysm is much higher than it is in Europe. Other data are beginning to show this. So I love being monolithic. I love giving you clear-cut answers. In this case, where Jacques asked me to talk about whether retreatments and stage treatments are a good idea, I'm going to have to be nuanced. I think when you look at an aneurysm, particularly in a frail or older patient, somebody who's ruptured, and you can dome protect them and then give them a permanent treatment later, that's a very feasible strategy that ought to be considered for difficult or complex aneurysms. But on the other hand, I think we're seeing far too many retreatments in this country, and we're probably hurting people in some cases more than we help them. Certainly in the 5-year Webbit data, to see that the retreatment risk is actually infinitely higher than the risk of any of those patients having a rupture from their index aneurysm, it's humbling. We don't want to be more dangerous than the pathology that we're trying to prevent. And in some cases, maybe we are. So I thank you for your time and attention. I think I'm well under time, but that's good because like Carlos and Chris, the most fun part of this is the conversation and the cases afterwards.
Thanks, Adam. As always, spectacular thoughts and putting together this complex literature and everything we've read and we've all experienced. Before I ask our two fellows to present you cases, I think maybe this is a good time to answer the audience questions and maybe chat a little bit about things. But let me start off with this. Aneurysms that are proven to grow. An aneurysm that was 3 millimeter, you follow it, it's 5 millimeter. Chris and Adam, you both touched up on this. I mean, I'm aware of a couple of studies that say that the risk of rupture becomes 12 to 20 times higher than the baseline, and to me is a license to treat. Are we in agreement or not? Chris?
So that is some of the Japanese literature where they follow these lesions very carefully and find that. And of course, what happens is when one of these things gets larger, and the first thing to be is to check, and I think AI may help this, did it really get bigger?
Right.
So, the cursor in the radiology suite was laid 1 pixel bigger, and the next thing, it's said to be 4 instead of 3. That is trivial, and we can often prove to the patient by going over the films with them that it hasn't really changed in shape or size. But it's the 4 millimeter or 3 millimeters that becomes a 6 millimeter aneurysm. Then everyone gets nervous, including the patient. And I think you're in pretty good standing to recommend treatment for that lesion if you can do it low risk.
Adam, do you use the growth as a definite indication to treat or not?
Definite growth is definitely associated with a higher risk of rupture. But like Chris, most of the patients referred to me with definite growth have not had growth. They've had a radiologist interpret it differently. And I've been in conferences where people use that as a justification to treat the patient, and I don't agree with that.
Carlos, any different thoughts?
No, ditto. I honestly, I remember when Brian Ho asked for any potential aneurysms. He was doing a study, and I went back through every single one that we had seen at Leahy over like a 10-year period. Not a single one had shown growth. So it's almost like that mythic unicorn. I'm not sure it really exists except in very, very rare circumstances.
So, Jacques, that raises the question, how often should these people really be screened? And as you know, this has been an interest of mine. We did a cost effectiveness analysis and came up with 2 years. But, I've met patients who are getting scans every 6 months with a 3 millimeter aneurysm. And I'm like, what is going on here? And realized, this has bigger implications for healthcare and health dollars. But as Carlos said, the number you see change over time is so small, you really wonder how often these patients should really be screened.
Yeah, I'll raise another specter. So now we have artificial intelligence companies that are giving you products where it can look at all CTAs done in a system and ping you anytime it detects an aneurysm, no matter what the size is. When they asked me about my opinion about these products, I said, you're going to hurt more people than you're going to help because of the aggression. So I think webinars like this, where we get people together, it's important to be clear on our culture. I know the ABNS is very serious about looking at post logs for people who are treating patients with that indication. We are going to have to kind of develop a culture of being real about what the indications for elective treatment of aneurysms are, and obviously growth is one metric, but I think we need to be real about with more endovascular has come more unindicated treatments.
And Adam, not only will you get pinged that there's an aneurysm that exists, it'll ping you as to when you should do the next scan. That's the next, it'll say, do a scan in 1.3 years or 1.5 years. Yeah, it's coming. I mean, it's here.
Chris, I remember, I don't know how many years ago, you wrote a paper, you suggested a score of, I think, 10 or 11 score categories to predict recanalization of aneurysms. What was it called?
So that was, there was no name, but it was actually a multi-center study of 1,500 endovascularly treated aneurysms. And it incorporated the completeness. So it looked at size, hemorrhage, no hemorrhage, and then how it was treated.
Right. And
completeness of treatment. And based on that, we could stratify risk of recanalization. And in fact, we had enough at the time pipeline treated patients that we included endovascular treatment into that. The point is, you know, a 5 millimeter or an 7 millimeter, really well coiled, tightly coiled aneurysm like Adam showed in the periclinoid location, completely coiled, the side wall, that the risk of that recanalizing is significantly different than the carotid bifurcation aneurysm that's 10 millimeters and grade 2 Raymond Roy grade 2 coiling. And it really, you can show that quite statistically. And so the big factors are size of aneurysm, thrombus, hemorrhage, no hemorrhage, and then treatment modality in terms of, this was all endovascular, completeness of treatment with coils, and then adding stent to coils significantly reduces recan rates and flow diversion.
Right, but I remember, I wish I had the paper, because I've used a graph in your paper to say, because in the top 6 or 7 categories, the recanalization rate was so high. I said, well, this is data that must justify clipping those cases if the data suggests that the recanalization rate is so high, at least in those higher risk groups.
Correct.
Correct. ARSS, wasn't it?
Correct. The large ruptured aneurysms, the giants, especially if they have thrombus, you got about like a 90 to 100% chance you're going to be retreating that aneurysm.
Right. Right.
And we used retreatment as a surrogate for recan.
Correct.
And Adam, just quick question. You had mentioned growing neck remnant with the web device. Did you mean growing neck remnant or compaction of the device?
Yeah, well,
actual, you know, because growth is different than compaction, right?
Right, but it can be hard to tell, right? Because the device is obviously different than a clip and it's different than coils. It's compressible. So in the 2 cases I showed that were retreated, the ruptured ACOM and the unruptured basilar, there was clearly a growth in the remnant that had not been treated originally. You know, the aneurysm healed where the web was, but where the web wasn't, it's not going to go away. And it might even grow a little bit over the initial placement. So that's what I meant.
Okay, let's tackle some audience questions. Albert Allen is delighted to be seeing Carlos David. Carlos, he's misguided into thinking you're a good guy, but anyway, he sends you his best.
Thank you, Albert.
And then I think he's asking whole blood transcriptome biomarkers of unruptured intracranial aneurysm. Future blood test for early detection, ? And maybe if I could also invite my partner, Bobby, to weigh into those conversations as well, if he's not called back to the angio suite. Anybody wants to chime in? Is this, will somebody be watching this webinar of today and laughing at us and saying, oh, look, they were in the Stone Age looking at linear diameter of an aneurysm? Anybody? No? Blood tests to predict rupture rate?
I think imaging is going to be far more sophisticated, and whether vessel wall imaging is going to work out with a 7T magnet. We're in a study with that now. But as you probably know, there are blood tests being developed. The group in Buffalo is working hard on this. Actually, the company was started by a patient whose wife, the diagnosis of subarachnoid hemorrhage was missed and she died. So he's funding this with great interest. But I think it may come up to be a sort of a multifaceted evaluation and using all the parameters, you know.
But it's important to note that this is experimental. It'd be great if it came out. And
Totally.
Chris, vessel wall imaging, right? Probably at this point, you'd have to say that's experimental, but promising.
I mean, the Helsinki
Totally
group,
experimental. And a lot of people are doing it and they don't know what to do with the data.
right?
Yeah, I mean, currently we're collecting blood, tissue, cells from a lot of patients in an effort, you know, and also collaborating with a number of other centers to try and develop, you know, a diagnostic test, a medical therapy, improved cellular and molecular based imaging, but you know, still ways to go for sure.
Ahmad Najjar would like to know if there is any long-term data on blister aneurysms. I guess, Carlos, what can you tell him about what you reviewed and your experience?
Yeah, you know, all those meta-analysis and the individual papers, the follow-ups were some as long as 9 years. So I think that is the follow-up, the long-term follow-up data. It seems like 77-ish% of patients do well with flow diversion, with, you know, relatively low morbidity and mortality in the 4 or 5% range.
So I will argue with that because that literature is entirely based on self-adjudicated, self-reported studies. And every disease we look at, when you really do a scientific study, there's a gap of usually around 20%. So we are doing the first adjudicated study on blister aneurysms. It's a multi-center study called Elevate. It's phosphocholine-coated flow diverters and 3 days of dual antiplatelets and then single antiplate with aspirin. I predict that that study, which is sponsored by Medtronic, is going to show much worse long-term numbers. Certainly, I mean, maybe it's just that I'm terrible at treating blister patients. In my personal case series over 18 years, it's not, you know, 77% are doing great. That's like I said, I see a lot of young women, horrible vasospasm, you know, and systemic illness. That's the other thing that, Carlos, you didn't mention. I find that patients with ruptured blister aneurysms are extremely creative about finding ways to get sick and die in the ICU. I've seen pulmonary complications. I've seen bleeding complications. I've seen Takotsubo's cardiomyopathy. You know, it isn't always re-rupture the aneurysm. It seems like they're just really ill. Is this just in Memphis?
Oh,
or
they are.
Okay.
They are. I told you that CFO that I treated, you know, I'm shocked that he survived and actually did well in the long run, but he was at death's door. We almost didn't treat him at all. They're really bad grade subarachnoid hemorrhage patients. And you know, that I'm telling you the literature that is out there, but that's why I prefaced it all by saying, what's the decision making when you don't have good data or a good answer? We really do need some randomized trials.
You know, I've sort of morphed to flow diversion if possible for these lesions. And when I first started doing it, the first couple of patients, I was angioing every 5 days to a week, and there the lesion was, and the patient was sick. And so finally I talked to the group at Jefferson who had published a series of them, and they said, don't look. Just leave them, look in a month, and sure enough, you know, then the thing's gone. But it takes a while, and they can look pretty bad for a while. It makes you very nervous that they're on dual antiplatelets.
Hurting your eyes more than the patient.
We've definitely had some that the blister looked that we pipelined or flow diverted that looked better at a 1 week when they have spasm, and we repeated at 2 weeks, and the aneurysm had grown significantly. And all of those ones, we've, you know, by then they're past most of the issues, and then we flow divert them again. I agree with Dr. Arthur. You know, I think most of these patients probably have some molecular problem, and they all seem to get severe vasospasm. They tend to have more Takotsubo's, and I bet there's some molecular or genetic, you know, trait that a lot of them share that we haven't figured out yet.
Okay.
Yeah, but
Oh,
those
go
of us who have tried to clip wrap them or sun clip them, it's interesting. Almost all of us are happy to see flow diverters. You know, I mean, I was with Gary Steinberg from Stanford this week, And man, nobody loves clipping an aneurysm more than Gary. And blister aneurysms came up and he said, no, I don't like those. I want the endovascular guys to do all of those. I don't want to do those. So it scars you. I think the younger guys who haven't done 24 blister aneurysms, maybe haven't had the psychological trauma that some of us have gone through.
And the sun clips were, they were great for the surgeon because they stopped the bleeding, but about a third of those patients had carotid occlusions, and happily, most of those were asymptomatic. But I've looked at some angios or there's a trickle of flow through them. I have 2 patients like that and one that's occluded, but they had good collateral. So we thought, oh, great, they got through it. They're moving everything. They did well. But that was the downside.
Well, that's where the flow probe and trapping, gets useful too, right? I mean, Carlos was showing that, but I know Jacques likes using the flow probe, and for a blister aneurysm, that can be very useful.
And ICG, you're right, absolutely.
Yeah. By the way, dumping things on endovascular people isn't limited to aneurysms. As you know, that's why Carl Heilmann is working on his e-shunt. He wants all the endovascular people to place that little e-shunt and be done with this shunts for NPH and pseudotumor. But
and subarachnoid hemorrhage, we just put to IRB subarachnoid hemorrhage for the e-shunt.
Right.
I think 7 patients have been treated with the e-shunt for subarach.
Oh, really? Okay.
For you, those of you who don't know the seed story behind that, he was doing a shunt revision at 2 a.m. on one of Adel Malik's patients. And he said, hell, if they're going to take and treat the aneurysm, they might as well figure out a way to treat the shunt. And he started talking, and that's how it came about.
Okay. Ahmad Najjar, another question. What is the risk of rupture of an ACOM aneurysm of 2 mm in a 10-year-old kid? Chris, talking about, well, you can, I don't know if you want to answer it specifically. Can you allude to the genetic difference in natural history, the Finnish, the Japanese, the North American? Why is the ACOM higher in Japanese rupture risk than it is in US? And just talk about this.
As you know, there's not an obvious answer to that. The other thing in this, sort of buried in this question, is the aneurysm in a child versus the aneurysm in a 70-year-old. And these are, if it's a real aneurysm, first of all, it was found for some odd reason, because, why is a kid getting scanned or studied? But as everyone here knows, the pediatric aneurysm is often a different animal with, more fusiform involvement of vessels and nasty. I don't know what the actual long life project. I mean, you could use the numbers and calculate the life projection of a risk of rupture for a 2 mm aneurysm. There is a number, but I think that's a patient that would be followed radiographically. And I bet if it grew, that would be very aggressively treated.
And Khaled Asi would like to ask, would you guys treat an enlarging asymptomatic cavernous aneurysm, carotid cavernous aneurysm? I would not, but whatever.
Devil's in the details, right? Many of the cavernous aneurysms I see are in little old ladies. And, obviously there's no risk of subarachnoid hemorrhage. So I think those can often be left alone. Enlarging, I mean, is it like we were talking about, it was 3 mm and then a radiologist read it as 4 mm. Even in a young patient, I wouldn't. But I think in general, cavernous aneurysms can be safely left alone. Alex Berenstein's group did a great paper on that, even when they become symptomatic. The symptomatic aneurysms in the cavernous segment that Alex's group followed, some of them would get symptomatic and then become asymptomatic again. So obviously, extradural aneurysms are a different thing.
Yeah, but the problem, Adam, is as Chris talked about earlier, what is said is not what is done. I mean, we all see in our practices. You remember that paper decades ago, it was called The Rape of the Spine. And now there is really a similar trend of, I don't know what we're going to call it, but this abuse of treating those bitsels. Even
I love that you're mentioning J.T. Robertson's address, The Rape of the Spine, when you're here.
Oh, was that? Oh, that's right. That was his. That's right.
JT.
Yeah.
But yeah, I mean, glass half full, glass half empty. We happen to be in one of the only fields that is actually looking at indications in the first year in practice. right? I saw a cardiologist when I was on my way back from the ABNS, and I told him what we were doing. And he said, wait a minute, you actually look at their cases? And I said, yes. He said, hell, if we did that in cardiology, we'd take away the boards for half the cardiologists in the United States. So, I mean, we do have a culture where we are talking about these things and trying to hold each other to a better standard. But yeah, you're right, Jacques. Endovascular is the new spine.
Question from Ali Khabaza. Great presentations. When do you guys add coils to a flow diverter in an unruptured aneurysm? Is general guidelines. Chris?
I tell you, I used to put coils in the giant aneurysms with flow diversion, and now it's pretty rare. Maybe Bobby has a perspective on that. But, you know, flow diversion the efficacy is so high without coils. And it's particularly if the patient has a mass effect. We've had such good luck of that once they get through the swelling and the aneurysm thrombosing that I really rarely use coils with a flow diverter.
Any other opinion on that?
There was a multi-center study put together at the University of Alabama that they never published, trying to find the threshold. And their data suggested that the threshold might be somewhere around 14 millimeters in size. But this business of flow diverted aneurysms rupturing acutely has really almost never been reported for non-giant or certainly smaller than 14 millimeter aneurysms. So I don't know, Chris, that you have to do it at all, but you certainly don't have to do it for small and medium aneurysms, in my opinion. I don't know, Bobby, you have a different opinion?
Yeah, someone else published a paper showing that if you use coils, you know, even when controlling for size and multivariate analysis, the obliteration rate goes up slightly, but the complication rate slightly goes up as well, which in my mind makes perfect sense. You know, you might be making the procedure a little bit more complicated, but, you know, even just putting a couple of loose coils in there will increase the chances that it obliterates. So I do still put, you know, a loose coiling in a lot of my aneurysms, especially the really giant ones. And then if I don't put coils in, I usually do one flow diverting stent. And if I don't see contrast stasis in the aneurysm, usually I'll place another one. I mean, I think that's the other controversial thing that we talked about when you go back to when we first started doing this, whenever it was like 9-10 years ago. Originally, we were placing like 4 flow diverting stents in every aneurysm, but they were giant. Then we moved all the way to the other end of the spectrum, just doing one flow diverting stent. And now I think a lot of times, if it's not necessarily for giant, it's usually 1 to 2 flow diverting stents.
It is interesting. We looked at flow stagnation after flow diversion, and it did not correlate with aneurysm obliteration. You know, if it stagnated, it had the same chance of obliterating of the non-stagnants. But it's something that might merit reevaluation now that that was early on in our experience, though.
Yeah, maybe, you know, we could look at it in the larger database now, but it seems like in the larger databases, those that have some stagnation have a higher chance of obliterating.
Okay, one last question before we present the 2 cases. What's your preference for from Edinson Najera? What's your preference for flow diversion type in blister-like aneurysms? Any difference in efficacy and safety? Have you seen stenosis of the parent artery in long term? I assume Edinson is asking about which type of flow diverter, pipeline versus others. Anybody would like to tackle this question?
Well, the Pipeline Shield is a surface modified flow diverter that has phosphocholine on it in an attempt to reduce thrombogenicity. And so I think as we go down that road, Pipeline Shield and then other stents that are coming that have some surface modification might be a good choice. Because obviously a lot of these patients require ventriculostomies and there are bleeding complications. So if we could do it without, you know, dousing everybody in heavy dual antiplatelets, I think that would be preferable. I'm not aware of any data that suggests that one brand or another is better in this specialized application, but, you know, surface modification is interesting.
Okay, Matt, my current external fellow, why don't we have you present the case you've prepared?
All right, so this is a case that Dr. Marcos and Dr. Stark were both involved in. So the case is a 40-year-old female who 3 years ago underwent a left terminal craniotomy for resection of a paraclinoid meningioma, who preoperatively did not have any aneurysms, but post-op serial imaging was actually found to have a growing left MCA aneurysm. On exam, she had actually decreased left eye vision from before the initial tumor resection, and otherwise she is neurologically intact. So here is the MRI of the original tumor before the first surgery. And if you look at the pre-op T2 and the post-op T2, it's pretty clean pre-op, but already on the post-op T2, there may be something suspicious at the MCA bifurcation.
Matt, for the audience, just if you use your pointer, show them what we're talking
Of
about.
course, yes.
And
So-
where it wasn't before.
Right, so
How far post-op was that, Matt?
this is within 1 week post-op, the immediate post-op MRI.
This is Chris, another partner of ours. I didn't do the first surgery. We asked him, he never had any problem with the MCA. He split the Sylvian fissure, took the clinoidal meningioma out, never encountered any bleeding. Very puzzling. Here, go ahead, Matt, show the before.
Yeah, and then here on the post-op, there's something suspicious already at the MCA bifurcation. And of course, the patient had multiple MRIs to track the tumor. And initially, the MRI post-op, even the 3-month post-op MRI, the radiologist did not call an aneurysm being present. But by the 8-month post-op MRI, the radiologist was able to pick up the aneurysm. And you can see by 20 months, it becomes more apparent, and I'll show you more. So you can see a little bit better on the T2 sequences, 8 months and then 20 months. It's definitely grown. And I'll show you another sequence. Here, 2 years post-op, now it's bigger. And you can see it definitely on the MRA. And so this is when this patient was referred to the Cerebrovascular clinic. And we did a angiogram. And the measurement was 7.1 millimeters at its largest dimension. And if you look more carefully, this is and I'll show you the 3D here. Oh, by the way, so the ECA injection shows a small frontal branch of the STA without a obvious parietal branch seen on that side. So here's the 3D spin. You can see this is actually an MCA trifurcation where there's a temporal M2 that comes
Matt,
out.
sorry, yeah, with your pointer, show inflow and outflow for the audience.
Yeah, so here it's a little bit easier to see. Here's M1, inflow, aneurysm neck here, aneurysm dome away from us. Here's a temporal M2 where the origin of the temporal M2 is just proximal to the sort of the true neck of the aneurysm. And then there are 2 frontal M2 branches that sort of come out of the aneurysm. And here is the more direct view. So now you're looking at the sort of the M1 here. M1 coming this way, and then temporal M2 here, and then the 2 frontal M2s.
Yeah,
And
and
the
just
Bobby,
to-
you want to comment? You did the angiogram.
Yeah, just to be clear, I mean, because I think it's very hard unless you really study these images. There is a pipe of an M2 that comes out of the
Bobby,
middle.
you're too far from the microphone. Your voice is not clear.
Sorry about that. So there's a pipe of an M2 that comes out of the middle of the aneurysm dome. There's one M2 that looks normal that comes out of the base, but the third M2 also, it's not really coming out of the base. It's coming out of sort of the lateral part of the aneurysm. So it's a little hard to see that here, but basically there's two M2s that are not coming out of the base whatsoever.
Go ahead, Matt.
Yeah. And so the question for our speakers today is, how would you manage or treat this aneurysm? And I can go back to this slide here.
And actually, even more importantly, how do you make sense of the pathogenesis of this aneurysm? I mean, all of us who've had pseudoaneurysm or aneurysm, I mean, you always get bleeding at the time of the initial quote unquote injury. Comments on?
So we're absolutely sure on other images it was not there pre-op.
Absolutely certain. We
So there
went
was.
over it.
So a week later, I think you have to, even though there was no encountered bleeding, you wonder if there was a retractor, if there was stretch on the vessel, and you created some intimal, little bruising of the vessel wall. It didn't bleed and then subsequently developed.
Yeah. Okay, comments on treatment? Well, I guess growing aneurysm, natural. Chris, you're our natural.
Well, this is not, I don't think this is a standard saccular, congenital aneurysm. Jock, your comments earlier, like we asked the surgeon, and Carlos's comments, it makes us all and the fact that we see it 10 days after surgery makes us all a little suspicious that it's a traumatic pseudoaneurysm. And of course, I've seen these types of things when after transsphenoidal surgery, sometimes a few years later that are growing. They're pretty straightforward to treat because you can use flow diversion through the cavernous carotid or supraclinoid carotid. This obviously more difficult because of the branches coming out of it, which may necessitate bypasses of one or two of those branches and occlusion of the lesion. Because I don't think a direct clipping is it'd be a tricky reconstruction to include those branches and not leave bad artery in the construct.
Okay, Adam, endovascular options.
So, Bobby's saying that there are two branches that come out of the aneurysm. I have to admit, having not had the opportunity to study it, I thought maybe we could stent assist coil, but he specified there's two branches, which means you'd have to do some kind of a, Y stent construct. But I think stent assisted coiling is what you're stuck with. I don't think a straight coiling is going to work. I don't think flow diversion's a great idea. This may be an aneurysm that's better treated with open surgery and possible bypass. If you only got one STA branch, you could see how long you could get it and do sort of a one donor, two recipients approach if you need to go to both of those branches, or maybe you can bypass one branch and clip reconstruct the aneurysm into the other branch.
Carlos?
So I'm looking at that. I think you could probably bypass to that one that's coming out of the dome. And honestly, I think you could probably clip reconstruct the rest of it and maybe augment with some cotton. But I'm not sure. Or you could rely on your favorite new bypass, doing the two vessels with one. But in my hands, I'd probably try to clip reconstruct with bypass just to that one that's under risk.
Okay. Matt, go ahead.
And I think, and we discussed it as a team, it's a little hard to see from those pictures, and when I was thinking about it for endovascular options, trying to come up with something that you could do with a stent or 3 balloons and then stent whichever ones you need to, but one of those branches comes out of the middle of the dome. So whenever I think something's going to need 2 bypasses, because there's 2 limbs there that I can figure out how it's going to clip, especially in someone who's young, that's usually someone I like to involve my partners to discuss, and especially Dr. Hiros and Dr. Marcos.
Matt, you want to go over?
So these options, I think our speakers already mentioned, it's not going to be simple coiling or simple clipping, whether we go endovascular or microsurgical options. And it warrants, oftentimes multi-surgeon discussion, stent assisted or balloon assisted coiling, or even post-rider assisted coiling. And I think bypass, if microsurgical option, bypass is most likely necessary. It would be difficult to just clip it without, allowing flow through, especially the big one that comes out of the dome of the aneurysm. And so what we did was we actually prepared this patient for an ECIC bypass with a radial artery graft. But what we were able to achieve in the end was actually a craniotomy with a temporal M2, one donor, two recipient to each of the frontal M2s that came out of the aneurysm. So a double bypass with just one donor, and then clipping of the aneurysm. So I'll show you the video briefly. I'm going to fast forward through some of this. So after a cilium fissure dissection, you can see the aneurysm actually, pretty superficial. And initially, we are doing kind of a combination of rachnoid dissection and sometimes necessitating corticectomies both on the frontal and the temporal lobe side, just because of prior surgery. And then we went ahead and looked for the M1.
And I think what's impressive there, which maybe it's hard to see, is like this aneurysm was entirely stuck to the bone and the dura all the way anteriorly where the craniotomy site was. So I think it must have been, from the prior surgery. It was completely stuck.
Exactly. Here you're seeing one of the M2s. Here's the other M2. These are two of the frontal M2s. And then the one on the left of the screen, that's the temporal M2, whose origin is just proximal to the neck of the aneurysm. So we're measuring flow. And I believe the temporal M2 was 15. The two other frontal M2s are 20 and mid to high 20s. And after looking at this, we felt that it was actually possible to do a one donor, two recipient bypass, where the first one that we did was screen left here, temporal M2, side-to-side bypass to the bigger M2, which comes out of the dome of the aneurysm. And so here we're first suturing the back wall of the aneurysm. Back wall of the bypass with a running technique. And then after that, checking for luminal patency to make sure we didn't grab any other walls, and then interrupt it for the frontal side. Here's the last stitch. And here's what it looks like after the side-to-side bypass. And we use flow measurement to make sure that it's patent. And at one point, we even put a clip proximally to the recipient and saw that the flow actually increased when we obviously occluded the inflow of this recipient M2. And so the next thing was to prepare the second frontal M2, the second recipient, for bypass. And here we're dissecting a more distal branch of the temporal M2. And to do a end to side bypass. Here we're kind of pulling this distal branch out and then swinging it to the frontal side to do a end to side bypass. We're fish mouthing the donor here.
You can go a little faster, Matt, just for the sake of time.
Yeah, so I'm going to just kind of skip through the bypass itself. Interrupted sutures. And then we began the final aneurysm dissection to prepare for clipping. We put a temporary clip on M1 to soften the aneurysm for safer dissection. And to allow better manipulation of the aneurysm, we clipped and then cut off the stump of the frontal M2 that had already gotten the bypass. And then we also did the same thing for the other frontal M2 that got the end to side bypass there. So now we can really manipulate the aneurysm more freely.
You know, the more you dissected this thing, the more it really looked so stuck. And it, in retrospect, it must be a dissection, a traumatic dissection that grew over time. It was so difficult to develop a plane around it.
Exactly, and we tried our best to dissect the temporal M2 off of the aneurysm wall, and it was completely stuck, as you can see here. And so the first clip that we tried was basically to clip the side of the aneurysm tangential, right here, tangential to the temporal M2 without stenosing the origin of it, which is on the back end of the aneurysm neck on the M1 side. And after we clipped it, you can see the origin of the temporal M2 is still patent. And then for the rest of the aneurysm, I'm just going to fast forward here. We first removed those two clips that were in the way, that were clamping the stumps of the two M2s, and tried a angled clip. And even this we felt it was not optimal. So then we decided to bipolar shrink it to make it more clippable, so that eventually we were able to put this angled clip on the aneurysm. And then when we examined this, there's a small gap here, even after we adjusted the angle clip. And so we first tried a mini clip and didn't exactly fill the gap. So we put a bigger, regular size clip to fill that gap, or to close that gap. And this is what it looks like in the end. So I'm going to go ahead.
Sorry, Jacques, question though, you know, obviously it wasn't there. A week later, it's there post-op. Why not treat it originally? Why wait and watch this?
It wasn't seen.
It wasn't seen. We got involved, whatever, a year and a half later or something.
And it wasn't noted by radiology as well. It wasn't until we looked back at the films, you could see that it had been progressively growing the whole time.
Yeah, too bad, because it would have been probably a lot easier to deal with.
Oh boy, yes, it would. Matt, is this a...
Yeah, so this is the post-op angio, and you can see there's no residual aneurysm seen, and the bypasses are patent. I'll show you the 3D reconstruction next. You can see the clips and the bypasses there.
Yeah, we never needed the radial artery, but it was nice to know, you know, that it was there.
Yeah, I was gonna ask you, it's a beautiful job, Jacques. It's a beautiful job. And I was gonna ask you about the radial artery. Did you harvest it?
We did.
Yeah.
We did.
And have you gotten away from saphenous vein altogether?
Almost, yes. I haven't used the saphenous vein in many years. Used to do them endoscopic harvesting.
Right, right. We would do it with the cardiac folks, and they'd
yeah.
harvest it while we prepared the aneurysm. Exactly.
To be honest, with flow measurements, you get more courage into using STAs. STAs are, you know,
But his STA was not good.
Oh yeah, no,
You know,
his
that's
STA
because of the previous surgery. That's the problem, you know.
Correct. That's why you know, and then the availability of the person doing the radial artery, you don't want them waiting hours to know if, you know what I mean? So we had to take it and never used it.
I didn't understand the logistics, and it factors into what we do, you know.
Yeah. So we thought this is an interesting case on pathogenesis and management. So thanks, Matt, for this nice presentation. And if I can go to Eva. Eva, are you ready to show your case? Talking about, go ahead.
Okay, so we actually have two cases. So the first one is a 46-year-old woman who presented to an outside hospital with thunderclap headache. And so then she was, they got a CT, then they transferred her to us for evaluation. And so on exam, she was somnolent, but easily arousable, otherwise intact. And so here was her her CT with a diffuse subarachnoid hemorrhage and hydro. And so we ended up, getting a CTA, an angio. And so this is what we saw on the angiogram. And so just wanted to, have the panelists describe to, just the audience what they see.
So, Adam, what is it?
The ruptured dorsal carotid blister aneurysm. It looks like the ones that Carlos showed. I think for trainees, it's very important to look for these. Classically, they're on the opposite side of the artery from the PCOM and anterior choroidal takeoff, and it looks like that's probably what we're dealing with here. They tend, whereas saccular aneurysms tend to follow Roten's rules and occur just past a branch, these are on a section of artery that doesn't have a branch, and rather than being saccular with a Murphy's tit on them, they look like a cone or volcano, and then they can rapidly expand. And if you don't catch them right off the bat, they can look more like a saccular aneurysm. But I think this is the classic.
And a persistent trigeminal artery, Jacques?
Yes, exactly. Exactly.
Which increases the chance of saccular aneurysms, but I'm not aware of any association with persistent fetal circulation and DCBAs. Maybe just,
yeah, I wasn't either. I assume it's a coincidence. Bobby, do we have reasons to believe this is more than a coincidence? Blister and persistent trigeminal and fetal PCOM?
I think like you said, that there's a higher incidence of aneurysm, but I don't know if we see a higher incidence of blister.
Yeah. Okay, Eva, go. Oh, so I guess what's your next slide, Eva? Okay.
Oh, just how they would manage the patient.
Well, the panel, I think, decided today it should be endovascular first chance of refusal. I assume that's what the panel will say. So I'm going to say
endovascular flow diverter, not
yes, of course,
and coil or all the other options you have listed there. Those been shown to be inferior. And from I would send it to my endovascular colleague for flow diversion. And if not an issue, if it is an issue for them, then I think this looks small enough that probably just clipping with cotton would do it.
Is that fetal directly opposite the aneurysm? Sorry. Is that a fetal PCOM without a P1 that's directly opposite the blister?
Yes, slightly. Yes, it is.
Does that change everybody's notion of?
You mean about surgical wrapping?
I don't know, Bobby, how you're thinking about these, but not really. Basically with the flow diverters, I think if a vessel needs to stay open, it stays open. If there's good collateral, it can go away asymptomatically. Is pretty much what we found. We've become respectful of that possibility, but I think I would still treat this with flow diversion.
The Elevate protocol we've developed based on the Australian experience with the phosphocholine coated stents is really not to give heparin or any antiplatelets until you drop the flow diverter. And then right at the time of dropping, we give integralin or another IV agent. And then 3 days of ticagrelor and aspirin, and then only aspirin. And what I like about that is that if you have EVD issues, you can deal with it because ticagrelor is very quick on and off. I have a little bit of a preference towards double or triple covering. If you put a given size flow diverter in, and then for your next one, go 1/4 millimeter larger in size, you're going to get a different braid angle. And so, at least theoretically in my head, I feel like, okay, well, maybe there's better coverage there than if you just put one stent in or the same size in twice.
I was going to ask if anyone would use more than one flow diverter at the initial treatment, because I've sort of headed there. Adam, one question for the study: how many patients are going to be entered in that, and what's the time course for that? Because these are so rare, to prospectively collect, it's going to take a little bit of time, huh?
Yeah, it could be an issue. I mean, it's a sponsored study. Again, thank you, Medtronic, for letting us study a difficult to treat and morbid patient population. But it's probably going to take several years. Our hope is that we'll get good adjudicated data out of it. But heck, the results may be so terrible that we're going to be at this webinar, in another year or two and talking about how, well, based on the Elevate study, we need to clip wrap every ruptured dorsal carotid blister aneurysm, because I do believe they're going to be worse results than what Carlos reported in the existing self-reported literature.
Adam, just for knowledge, what's your recipe, assuming, let's say, 2 weeks later, she needs a shunt? What do you do?
Well, at this point, they're just on aspirin at 2 weeks with this protocol. So I would shunt them on aspirin.
Okay.
So the reason I brought up that fetal is because I think just in regards to your two comments, I don't think one flow diverter has any chance of making this go away if it's directly opposite the blister, because that's going to be disease. So I would say you're going to need at least two up front, and I would say there's a good chance you're going to need to come back and place another one down the road. And then just in regards to the shunt, a lot of times we just take the person to the OR, cut the EVD, and then open the incision and put the valve in, so you're not repassing another EVD through the brain on aspirin flavus.
Eva, go ahead.
Yeah, so our endovascular colleagues, they actually ended up putting a pipeline.
This is prior to Bobby's joining us.
Yeah, so they put one pipeline across the aneurysm. And so this is the red arrows are where the pipeline ends and begins. And so then 6 weeks later, they actually got a repeat angio. And so like what Dr. Stark said, it ended up recurring. And now the aneurysm is actually bigger than before. And so the yellow arrows show, where the pipeline is. So now we just wanted to see, get from a panelist what they would do now that this has recurred.
So Bobby, you were right. One was not enough. The aneurysm is growing, but thankfully not rupturing. What would you do now?
Yeah, personally, I like the idea of placing another pipeline or potentially even two more flow diverting stents within this rather than an open option. I'd have to look at the films. I think that the tough thing about the open option is obviously that fetal system on the opposite side, which is going to need a temporary clip and a proximal clip and a distal clip with, so I'd probably place another flow diverting stent, and I would consider placing, two and bringing them back and placing another one if they needed it.
Yeah.
Eva, what did we do?
So they ended up putting one additional pipeline stent in a telescoping arrangement within the old pipeline stent, and then did an angioplasty. And so here's the red arrows are where the pipeline is. And so now they did another angio 6 weeks after the placement of the second PED. And so here's what we see.
Looks kind of short. It looks kind of short on that view. These need to be really well opposed, especially if you're putting another flow diverter within a flow diverter.
So Bobby, don't you think into the MCA?
Yeah, completely.
That's, the problem with the pipeline is as soon as you drop it with the carotid shape like that, even if it's up towards the distal end of the carotid, when you drop the proximal end, I think everyone knows this, but the distal end foreshortens. And it comes often for PCOM aneurysms, comes really close to them. So lots of people are just routinely putting them into the MCA for lesions in this location.
So you guys are saying he should have covered more distally?
Yes.
That's the
thinking. I totally agree with Chris. Yes. The other thing is, even though, we're worried about a ruptured aneurysm re-rupturing, there is stasis. So it's not like there's no flow diverting effect. And,
right.
And, in this growing aneurysm, you probably did a third one, but, it hasn't re-ruptured. This is something that if we, had the opportunity to run the experiment, it might actually heal, even though it's still there and it's grown a little bit because of how slow it looks like it is. But I agree with Chris. I think a little bit distal and probably a third one now.
You think the flow pattern inside the aneurysm would be different if this second flow diverter was longer or more distally? If he crossed the neck, does it matter how long the flow diverter is?
Well, yeah, I don't know about for this aneurysm, Jacques, but for saccular aneurysms, the longer the flow diverter, the better the occlusion rate. We published a paper with a group from Calgary looking specifically at that. But this is a different animal, obviously, so I can't really.
Well, but Chris, you're the one who said earlier, the Jefferson guys told you just don't look for a month.
Yeah, exactly.
So you might not look at this in a month and it would totally go away, but we looked So now, Eva, I suspect you guys did another flow diverter.
No,
Uh,
actually,
No, this time he asked me what would I do. So
Ah.
he was worried. I mean, you know, he's superb. He's an excellent technical endovascular. I had to trust him that this is not working according to him, and he asked me, should we do surgery? And I said, well, if you think it's not working, sure, I'll operate. So Eva, what did we do?
yeah, so we ended up, oh, so by the way, he also did a BTO and then.
Oh yeah, failed BTO.
Yeah, failed BTO. And then here was the right vertebral injection with the right ICA BTO. So there's no collaterals from PCOM. And then with the SPEC study as well, there's radio tracer in the left hemisphere that doesn't cross into the right hemisphere. And so, you know, because of all of this, and because he had asked us, you know, if we could do surgery, we ended up planning for suction decompression with a Dallas maneuver to see if that would help to decompress the aneurysm and allow us to clip it. But
sorry, Eva, 1 second, just for the audience. I'm sure the audience may realize you can. No, keep playing the video. We don't want to waste time, but you cannot. I mean, I don't dare put a temporary clip across a pipeline that it deforms it. I'm told irreversibly. So that was not an option for me. Go ahead, Eva.
yeah, so here you can see the pipeline, and then here's the aneurysm, and then you'll see here later it's M1 and A1. It's going to be coming off from here. And so,
so I don't know, guys, but you'll see in a second, his pipeline is quite a bit distal to the aneurysm. You see where the aneurysm finishes. I mean, there's a lot of pipeline beyond it. There's the A1. You saw A1. You saw the ICA bifurcation there.
A1, yeah, and then we end up doing, you know, placing temporary clips and then doing suction decompression, which, you know, we tried, but we didn't think it would work anyways because he had 2 pipelines and he also had that persistent trigeminal. And so as we expected, the suction decompression actually failed. So we ended up using adenosine to, you know, help with the clipping. And so it actually ended up allowing us to clip the aneurysm. So we ended up doing a side angled clip and a bayoneted clip.
So again, for the audience, adenosine given at the time of clipping, I find in some tough aneurysms very helpful in softening it when you have no proximal control. And then, you know, you tell anesthesia, give it now, tell me when you're in asystole. The minute it's in asystole, you close the clip. I picked up that from Juha Hernesniemi when he was in Helsinki. And
Jacques, another really nice job. It looks though on this, when you explored it, and also from the angios, that the neck was pretty crisp.
Exactly. Now, you know.
So that's nice, you know, because usually, as Carlos has shown us, usually the neck, there is no neck. So here it's evolved to the point where you've got something you can actually go in and clip. It didn't rupture in your face. And it was pretty crisp that you could see both sides of the neck nicely.
Exactly. It's actually a wonderful use of complement techniques, you know. I mean, yes, his treatment should have worked, probably due to the fetal PCOM didn't. Now, 2 months later, my job is a lot easier. I'm not really dealing with a blister. It's a well-formed wall. Interesting, isn't it? The wall is so well-formed, even though it was a blister to begin with. So that worked very well. So I thought that was an interesting, unusual failure of flow diversion on those.
So yeah, so now this is our second.
What time is it? Let's see. Yes. So we have a case, Bobby and I, in-house right now this week, and probably Bobby and I spent probably 2 hours discussing the case. We thought we'll get, Adam may know the case, but we don't want to spend too much time because it's already 2 hours, but Eva, do it briefly and we'll get the opinion of the panelists.
So basically, he's an 11-year-old male with hemifacial hypertrophy and astigmatism in the left eye. And so just briefly, he started having a headache 12 days prior to presentation, as well as blurry vision. And because his prior history of astigmatism, they thought that it was just from his astigmatism. And they brought him to the ER, they gave him a migraine cocktail, and then the headache improved, and then he was sent home. And so then 4 days prior to presentation, he's had again decreased vision in the left eye. And so, you know, because of the astigmatism, they didn't think much of it, and they didn't get any CT scans to try to avoid radiation. And so then a few days later, he again had no improvement in the vision. And so he was brought to an ophthalmologist who then saw, decided to refer the patient to the ER. And so on exam, he had light perception in the left eye and he was otherwise intact. And so here was his MRI that they ended up getting.
So he's got this syndrome of, I have to read about it.
Yeah, he's got hemifacial microsomia, which is actually usually associated with like vasculitis and also usually a lot of vascular problems in the chest, like dextrocardia and things like that. Not so much aneurysms in it, with the exception of like vasculitic changes.
And he had Bobby, his parents were telling me, I mean, he had surgery for his skull for like, it's not craniosynostosis, but some
hemifacial microsomia. So they have a skull problem and they basically put, I think, fat in to help repair the defect.
Right. So Bobby, you want to just describe the angio, what it shows?
Yeah, I mean, he's basically got this fusiform dolichoattatic aneurysm that starts in the cavernous segment and goes all the way through the supraclinoid segment, and then the A1 is very irregular and then turns into a fusiform aneurysm. I mean, I think some of the real challenges that are, without studying the films, if you pause it right there, the left A2 comes out of the dome of that fusiform ACA aneurysm, so that's key. And it's not very well fed by the right side. So
she may have the 3D. Do you have the 3D, Eva, next?
Yeah, I have the right IC injection too.
then the anterior choroidal artery, which you'll see here, comes out of sort of the supraclinoid segment that's sort of triangular.
So essentially, it's two fusiform aneurysms. One is easy to understand, which is the carotid up to the anterior choroidal, and then a second left A1, A2 fusiform. And he's lost vision acutely in the left eye, barely some light perception.
And pardon my ignorance, what do you think that's from, Jacques? The lower aneurysm or the upper, bigger one? More distal?
I think it's a lower
Yeah,
one.
that's what I would
will
think
see
too.
On the cross-sectional studies, this
That's
thing
what I was thinking.
way
Yeah.
up. It's way high.
I don't know if you have the 3D that we did with the skull reconstruction, Eva, but the interesting thing is this is pushed really high. So his ICA aneurysm is way above the clinoid. Even most of this part that looks cavernous, a good portion of that is above the clinoid.
So tough case. Chris,
I mean, these cases, like you guys are doing appropriately, they take me sitting in front of the computer looking at all the images out. I just spent a lot of time with these, but reflex kind of thinking, distal ACA bypass, and proximal flow diversion reconstruction of the carotid. Just to throw it out there.
Yeah. What does the order matter? Flow diversion, you need dual antiplatelets. I don't love doing bypasses with Plavix on board. Aspirin is okay, but not Plavix.
So if you think that the proximal lesion is the urgent, the visual causing lesion, you could treat that, and then that puts, like you say, that puts the distal lesion on hold for a while. A pretty extended time.
Well, the problem is, as you know, they're interrelated because the ACA is what might be the collateral to the MCA. It's tough to treat one and go beyond a point of no return. So we thought we should deal with the entire situation in one go. One go doesn't mean one method. One could be surgical, one could be endovascular. I mean, I don't want to drag this too long. I just thought we'll, unless, you hear your opinion, but we're actually planning this Saturday to do, well, exactly, I mean, what you're saying, but a double bypass. radial artery to MCA and A3 to A3 bypass. I told, Bobby has been thinking, well, is there a decent endovascular option to treat the whole thing? And I'll let him speak, but back and forth. I mean, I'm not sure what the right answer is, but I thought, look, I'd rather do more rather than less on this 11.
So after the bypasses, you're planning to deconstruct, or are you going to then do?
Trap, yeah, to trap.
I don't know. I wrote down about 20 options that I came up with for this and just tried to start like putting them in order. I really can't say that I was too happy with any of the endovascular options. I mean, I think the whole segment is disease. So whether you sack the ACA and flow divert the bottom, or whether you sack the bottom and then come back and deal with the top, I don't think those were good options. I mean, at one point I was sort of leaning towards a radial bypass for the MCA, and then testing the ACA and considering just sacking the ACA. But I don't know that there's a great option. I don't know that we need the distal bypass for the ACA, but maybe that's something that we can test intraoperatively after doing a radial to MCA bypass. I guess that's my one thought. The outflow from the A2 is very slow. So my hope would be one bypass and we can trap everything else. But the other option would be to be prepared to do a distal A3. And
I was asking Bobby if he had a good way to do a BTO of the left A1, because that would certainly simplify it if we don't have to do a bypass distally. But there is a picture you don't see. There is a layer of thrombus in the carotid aneurysm, and Bobby was not too keen on crossing the big aneurysm to go test the left A1.
So there's a there's a stenosis right there. So if you came from the left ICA, I wouldn't want to go through that aneurysm and put a balloon in the A1. I mean, at one point I was thinking, well, we could put up a balloon. We could put a balloon in the left ICA and do a run from the right ICA, and that would show us the left A1, and then we can come across the ACOM and down the A1 and put a balloon in. But again, you're going to be putting a balloon across the ACOM through that dysmorphic segment. And I just didn't think that that was a reasonably safe option.
Sorry, it's a complicated one, but we thought we'll use your presence today, since Bobby and I have been chatting about this the last couple of days. Maybe we'll show the case in the next M&M conference, or
Jacques, I wonder long term what's going to happen. Bypasses, occluding, changing flow dynamics in a kid who's obviously got something wrong with his vessels. What's going to be the next surprise?
I don't know. I mean, I guess Bobby has already. I have not read about the syndrome to see what we know about it regarding blood vessels, but
I started making the slides for the Jackson Hole meeting.
Take my name off it. Say it's all your complication.
If it goes
It's a
perfectly,
tough case.
it's
Good
Dr.
luck, guys.
Marcos. But if there's any issue, of course, it's all me.
That's right. Guys, I thank you we kept you 2 hours, 10 minutes, spectacular conversations. Adam and I have a dinner to go to. Adam, I'll see you at dinner in a few minutes. Thank you for the audience. Thank you for excellent talks. See you all soon.
Thank you, Jacques.